Communication skills have obvious benefits, and an entire industry has developed to train them. Healthcare has focused on patient communication for some time, but it has been slower to adopt team-based communication training. Communication errors contribute to as much as 80% of serious adverse events in UK healthcare. In the USA, the Joint Commission accredits and certifies healthcare providers. Its data indicate that over 75% of sentinel events in healthcare, and a similar proportion of such events that resulted in the death of a patient, poor communication was among the root causes. Without thought or training, people tend to act on impulse. Impulsive reactions are primitive and simple, and focused on short-term self-interest. They are rarely appropriate when multidisciplinary teams are working towards complex goals. The alternative to impulse is reflection. Reflective reactions require consideration, thought or training, without which impulse remains the default. This dichotomy pervades human behaviour, and impulsive behaviour, despite years of training and education, is a common experience. Tasks that are particularly prone to impulsive behaviour are those that require little concentration or thought. First among these is speaking in one's mother tongue, which is why impulsive versus reflective behaviour is such an issue in communication. We cover various aspects of communication skills, but if there is one overriding message for improving our communication, it is this: think before speaking. Now let's talk about theory. Communication theory is about developing generalized models in the hope that they explain more about a situation than the real life and experimental observations from which they were derived. What we want to know is specifically how to improve communication in healthcare. Current theoretical models do not really add to observational results in this regard, so we will not spend a lot of time on them, but we have used one model to classify communication issues into those of sender, message, channel and receiver, or SMCR. One of the first modern communication models was used for telephone research at Bell Laboratories. In 1949, Shannon and Weaver divided communication into encoding, transmission and decoding of the message. The message is subject to noise or interference during transmission. The relevance to telephony is obvious, but this model can also be applied to non-telephonic communication where noise is one of many sources of inaccuracy. The model did not give a complete description and was expanded by Berlow in 1960 into 4 parts, creating the SMCR model of sender, message, channel, receiver. All parts of this process are subject to noise, and errors arising at any stage are transmitted through the rest, so that the final error rate is cumulative. The importance of feedback in communication was addressed by Schramm in 1954. He described a two-way model in which communication goes from the sender to the receiver and back. This feedback can either confirm that the receiver has understood what the sender intended, or it can be corrective. This was further expanded in 1970 by Barnlund. In his transactional model, the sender and receiver have fields of experience that depend on the individual's culture, background, past experience, attitudes and beliefs. When these fields are shared, communication is more effective. As communication proceeds, the area of overlap between the communicants' fields of understanding expands. Both sender and receiver can adapt their mental models in the light of the message and its feedback, improving communication further. Join us in the next video and we'll look at the sender part of the model we've been discussing.